I am here on the educational team, and we're happy that so many of you could join us today. Today's webinar is the Coordination of Care and Medical Co-Management. This webinar is part of ACCC's Transplant Treatment Path, Optimizing Patient-Centered Care for ASCT in Multiple Myeloma. It's an ACCC educational initiative aimed at improving provider communication to optimize the treatment of multiple myeloma patients in the community cancer center pre and post autologous stem cell transplant, or ASCT. Financial support for today's webinar is provided by Celgene. The webinar will be presented by Dr. Joe Kim and feature Leona Holmberg, MD and PhD from the Seattle Cancer Care Alliance in Seattle, Washington. Dr. Holmberg specializes in bone marrow transplantation and has clinical expertise in immunotherapy and transplantation immunology. A couple of reminders for today's webinar. If you look at your screen, you're going to notice that there's a questions box in the lower right-hand side of your screen. All of our lines are going to be muted today for audio, so if you'd like to ask a question, go ahead and type it here and hit send, and we will get through as many as we can during today's broadcast. Those that we don't get through, we're going to collect and send to Dr. Kim and Dr. Holmberg to have them answer them after the session, and we will send you any of those as well. So at this time, I'd like to turn the session over to Dr. Kim.
Great. Thank you very much, Daryl. It's a pleasure to be on this webinar. For those on the webinar today, I just want to remind you that this is webinar number 3, and we've actually had 2 preceding webinars all covering different aspects of this project around multiple myeloma. And so as we go through some of the slides and talk about this, we'll be referring to some of the content that might have also been covered in previous webinars. Those 2 have been recorded, and they will be available on the ACCC website. But before we go on, let me just allow Dr. Holmberg to introduce herself. Please tell us about your role within Seattle Cancer Care Alliance. I know that also within your transplant program for myeloma, you all do transplants as an outpatient. So just tell us about the program. Tell us about your role.
Good afternoon. I'm a member of Fred Hutchinson. I'm affiliated with the Seattle Cancer Care Alliance and the University of Washington. Got about 20 years of stem cell transplant experience. I do, in fact, do a heavy clinical load. I attend about 6 to 7 months a year on the transplant service, do a number of transplant consults, and also the liaison for our autologous transplant patients with our long-term follow-up program. And I run a number of clinical trials that are associated with both autologous and allogeneic transplants and maintenance therapy post-transplant, especially for myelomas, but also for lymphoma patients. We have a robust transplant center here at the Fred Hutchinson SCCA UW program. We basically do about 40% of our business is autologous. The rest are allogeneic transplants. With autologous transplants, most commonly what we do is multiple myeloma. We, a number of years ago, developed an outpatient transplant service where we try to keep people out of the hospital as much as possible and really just admit to the hospital when we have to for medical issues. And so in our myeloma program, for example, about 40% to 30% of our patients are never hospitalized. They do the transplant totally in the outpatient setting.
Great. Well, thank you very much for that introduction, and I look forward to having a discussion as we move on. So let's move on to the next slide, and we'll just quickly review the background of this project. We know that with a lot of these multiple myeloma patients who are being diagnosed in the community setting and who ultimately require transplant, many of these patients are being referred to tertiary care academic centers, and they need to travel in many situations. And so as they go back and forth from the transplant center back to the community, back to their primary oncologist, there seem to have been some gaps in that care, whether it's around care coordination, communication, medical record transmissions, etc. So the goal of this initiative was really to look for key ways to improve the process and the communication between those referring practices and the transplant centers. This project was funded by Celgene, and we also had BMT InfoNet join us as a partner. And on the next slide, you'll actually see a list of the transplant centers as well as a handful of referring practices within each of the regions that participated in these quality improvement workshops. Prior to the workshops, we had every center sort of fill out some questionnaires and look at their processes, and then we pull people together in interdisciplinary group to really talk about things from the care coordination aspect, the records, the medical records, as well as just how are patients being managed both before they go as well as after they get their transplant and return back into the community. So at Seattle Cancer Care Alliance, we actually had some practices that were from that area as well as from Oregon, as you'll see from this list. But you'll also see that there were other programs that participated in this initiative as well. On the next slide, you'll see that prior to actually conducting the workshops, we actually did a needs assessment survey. And on this survey, we actually asked each of the programs, whether they were an outpatient oncology practice or a transplant center, we asked them, what are some of the key strengths and key opportunities for improvement? And you'll see that the common theme across the board is that whether they were referring practice or transplant center, that just having that strong clinical staff, obviously expertise at the transplant center and then access to clinical trials was a real important aspect. And they all agreed that when it came to communication, when it came to logistical issues that patients face, these are some of the barriers and challenges that they face. And even though most of these organizations are on electronic health records, they all agreed that there was still room to improve from that process of obtaining records and sending the records to getting discharge summaries and lab reports, etc. So we really talked about that from a regional perspective and wanted to gain a better understanding, and that was really the purpose of the workshops. Now, on the next slide, you'll see that the Centers for Medicare and Medicaid Services, CMS, has outlined a series of quality strategy goals for this country. And even though we have state-of-the-art care available in this country, and we have excellent clinicians and research expertise, etc., if you look on the lower right, number 3, one of the key areas that CMS really needs us to improve in is promoting that effective communication and coordination of care. Because of the fact that so much of healthcare today is fragmented, and there is room to improve depending on where you're located in this country, as well as how your providers are communicating and whether it's truly integrated or if you still have a lot of independent providers out there. And so with that in mind, we really wanted to just focus on some elements that would resonate with the needs of each community, understanding that the structure, the dynamics, the market forces are very distinct. So just moving on to the next slide, and we're moving through some of these sort of introductory materials fairly quickly, but as I mentioned before, a lot of this information is available on the ACCC website, and there have also been some preceding webinars. You'll see here that this is just an example of a tool that the James uses at The Ohio State University. And the reason that this is there is that what we have found over and over is that particularly when patients are referred to a major academic medical center, and they're seeing a lot of different people, and many of these folks may be wearing white coats and may not be wearing white coats, these patients often get very confused. And one of the common comments that comes back is that when they're in the community and they go to see their primary oncologist, these patients, generally speaking, know who each person is. But then they go to a major center and all of a sudden they're greeted by all these people. So the purpose of this was just to remind everyone on the webinar that if your organization say the transplant coordinator versus the social worker. That this is an example and sort of a reminder for all of us that these kinds of tools can be very helpful for patients, particularly for those who may not be very familiar with, once again, interacting with large medical systems and large hospitals. Moving on to the next slide, we spent a significant amount of time during the workshops talking about health information technology, or health IT. And we know that in health IT, there are both challenges as well as opportunities to really use IT as an enabler that improves communication, care coordination, etc. And yet, every time we went to these workshops, whether we were talking to people at a large health system or talking to people from an outpatient oncology practice, they all kind of resonated that even though they've been using these IT systems for a while, they still face a number of different challenges. And I guess at this point, I'd like to ask, Dr. Holmberg, I mean, here on this slide, we list some of the challenges in health IT. Based on your experience working at SCCA and using IT for different things, I mean, would you say that these are reflective of some of the challenges and issues that you're having, or are there perhaps other challenges and issues that you'd like to just address briefly here?
So I think that the IT medical record has, in fact, decreased redundancy from back in our paper world. It does make it more clear. We're a rotation system where we have the people who are caring for you in the hospital when you get admitted are a different team of doctors and caring for you in the outpatient, and every month everybody rotates in our system. Our tiers of physicians are the attending as well as a primary care provider, could be a fellow in training or a PA that we've hired and trained to take care of our transplant patients. So I think the IT system makes it better for us to really clearly communicate with each other and also to know what medications people are on. That's similar to when we're discharging somebody home, our pharmacist will create an electronic medical sheet that's all the meds the patient's on. We give copies to the patient, and we also give copies to them to hand deliver to their doc when they see their doc the first time. We also have them hand deliver copies of their scans in our system, so the doc will have them for future comparisons, and then summary of their course while they were under our care.
I see. Okay. Great to hear, and we'll be spending some more time, I know, talking specifically about the different ways that you all are using IT up there in Seattle. One of the key themes that just kept coming up over and over is the barrier of interoperability. And what we found is that every state, every city, every region, every town is either dealing with interoperability in different ways. And so we'll talk a little bit more specifically about what's happening in Seattle there. But let's move on to the next slide here, because this slide, which is a busy slide and it's got a lot of text, is really meant to be a schematic and remind all of us that, IT really is meant to be an enabler, and it's designed to improve that communication across providers, whether it's providers within the same system, or ideally, even across providers who are parts of different systems. But then, of course, we also know that it's designed to engage and empower patients. We're seeing more and more systems now leveraging patient portals. And we've also talked to some practices that even though they may have a patient portal, they're not actively promoting it or using it because they just don't feel like the capabilities and the functionality is where they would like it to be, or perhaps their patient population and the demographics are just not the kinds who would actively leverage the patient portal. So we know that across the country we are at very different places, and I think if we were to spend a lot of time on this schematic, we would realize that everyone, even on this webinar, could probably relate to some of the areas where IT has really been an enabler, as well as where it continues to remain a challenge. On the next slide here, we'll see that the government has invested a tremendous amount of resources financially through meaningful use and the different meaningful use requirements, but also through a number of other initiatives through Medicare and others, with the idea that, we're now past this first phase of just collecting that patient information. You need to have an electronic record, you need to collect the information. We're now really at this main center section where I think across the country many organizations are really looking for practical solutions. How can they effectively share that information across different health systems, hospitals, between a major center versus a private practice? And I think that's really where some people are getting stuck. And other parts of the country where you've got a lot of integrated delivery networks or really, really robust health information exchanges, HIEs, where they're being much more effective. And I think ideally, the bottom here where the ideal and the goal is that once you've gotten enough of this data, that you can actually mine that data, use it in a way, do some big data analytics, use that information for predictive decision-making and really empower the clinicians to treat patients. And there are a lot of exciting projects that we're hearing about, certainly in the world of oncology, where they're looking at data and looking at it from that perspective. On the next slide, we'll see that the health IT ecosystem really does include a number of different pieces and elements. And in order for us to be able to really bridge some of these gaps, between the patient and the practice and the population, is that everyone has to ultimately be on the same page. They have to understand what's happening on the policy level, also understand what's happening from a technology perspective around clinical decision support tools and some of these analytic tools and artificial intelligence, and ultimately be able to personalize that application to where they are practicing based on the kinds of resources they have, the things that they're able to tap into. So we're going to come back to this IT topic in just a minute, because I think up in Seattle you all have some great things going on. But just moving on to the next slide, one of the big areas that we spent a lot of time discussing was around this idea of medical co-management. And I think that term can mean different things to different people, but we really wanted to gain a better understanding of when patients were being referred for transplant. You could either just fill out a referral form and fax it. You could have the patient call in, or you could have the office staff call in and they just provide some information. Or in many cases, the physician would actually talk, the primary oncologist in the community would actually talk to the transplant physician, discuss the patient even before that transplant physician has seen the patient, and ask, do you think I should even refer this patient, or what do you think I should be doing in the meanwhile? And then having that conversation continuing when that patient is discharged from transplant and returning back into the community. And I guess, Dr. Holmberg, just tell us a little bit about at Seattle Cancer Care Alliance, when patients are being referred to you, how often are you actually spending time speaking to some of those community oncologists about these patients before they come see you? And then what is the level of communication that you provide to those physicians after they finish their transplant?
So there's two phases to this. We have a very structural approach, and then there's also relationships you already have with referring oncologists who will call you as an individual to ask your opinion. Our structure is we have a whole intake office that has a rotating attending physician every month, and it fields calls from both patients in transplant that have interest, as well as referring docs, and we advertise that you can, as a patient, call in and just talk to a transplant physician because we have someone that mans the office every day, which is a little unique from some other centers where you don't really get that talking right directly to a transplant physician. About probably half of our patients come in as a consult before they come in to be a transplant patient. So they either come by directly requesting themselves to be seen in consult by a transplant physician, or their doc has requested it for them. Some patients, it's elected based on when they talk to the intake attending physician that they don't really need to be a consult. I mean, we know what we wanted, what their options for therapy are and what's appropriate for them, and we can just bring them directly into our system to be a transplant patient from the beginning. On the flip side, we have a standard practice that's very robust here, and we basically outline how to work up a patient for a transplant, how to deal with all the collection issues in an autologous setting when you're trying to collect stem cells, how to approach all of the toxicities that we see, either unique, but even some rare ones that are severe enough that we call them out and we've recognized make recommendations how to manage the patients. We also have about a 250 standard practice manual that's called long-term follow-up of patients, both autos and allos, that we give access to every doc referring oncologist we send a patient home to, which does the same thing. It says, these are your common problems, this is what to think about, this is how to manage the patients. And then we have a very robust long-term follow-up office, which patients can call into, as well as referring oncologists, and then an oncologist will be talked to by another physician. In the patient's case, they are screened by a transplant nurse first, and if it's something that's very easy to answer, the transplant nurse will just deal with it. But if it needs to be punted up, then it goes to a physician. The physician will then call back or at least be advised.
Mm-hmm. Okay. Well, thank you very much. I mean, here on the next slide, I think, we're going to talk more specifically about the kind of information that gets sent back and forth, because a common theme that came up over and over was, okay, there's a lot of care coordination obviously that's happening as patients are being referred for transplant, and they get evaluated at the transplant center, and then they get their transplant. But then what happens when they then go back to the primary oncologist for that follow-up and sort of ongoing maintenance therapy if they require it, et cetera? And on that post-transplant sort of discharge summary section, we found that in many situations, the discharge summary is printed out. It's mailed, physically mailed out, either through the Postal Service or FedEx, UPS, or some other courier service. And it may take a really long time to reach the primary oncologist. In the meanwhile, in some situations, the patient may have already scheduled a follow-up appointment with the primary oncologist, and in some instances, the patient shows up and the primary oncologist's office does not have any discharge records. So I guess tell us a little bit about, at SCCA, how do you all communicate that post-transplant information back to the referring oncologists?
Well, I will say that we, for a number of years, did exactly what you alluded to originally, which is that we would dictate a discharge letter, and then we also would have the primary care provider, independent of the attending, do a summary discharge. And that was all mailed. And it was very cumbersome and very slow. That is correct. We've been more recently trying to rectify that by initiating a different system where that we do try to, although this is still kind of not totally gone into 100% of doing it, where that we see the patient, the attending, for a discharge conference a few days before they're really leaving our transplant service, and that therefore they can have in hand a letter just from the attending, so that the physician will only have one source of document to look at, won't be bombarded with a couple of different documents to evaluate, and that they can get in more real time. We've also converted to faxing those instead of mailing them. As I said, we're in the process of doing that 100%, but that's kind of a moving target right now, still with us. Yeah,
and we certainly understand. I mean, even when we left these workshops and have followed up with some of these centers, there are still a number of process changes and process improvements that are still in process. So, but that certainly sounds like you've got a number of things going that way. So, on this next slide here, you'll see just one other example of a consult checklist, which you had mentioned briefly in terms of some of that structured approach to collecting the information from referring oncologists. So this is an example from Emory, and of course, even when we had the workshop there, they continued to sort of refine their ideas on what kind of information they wanted to collect from referring oncologists. And on the next slide, I know that at Seattle, specifically through your University of Washington's electronic health record, that you all have set up there something called ULink. And even during our workshop, as we were talking about ULink and talking about how patient records don't necessarily have to be faxed or mailed, they can be accessed electronically even if you are not on the same record system. So tell us a little bit about how ULink is being utilized within that greater Seattle area.
Well, I mean, the issue with ULink is who has access to it. Definitely the people in our network, and our network is where we went out to local oncology groups in the Pacific Northwest, because our network is beyond Washington. Really, what we treat is anywhere from Alaska into Hawaii, Washington, Idaho, Montana. That's kind of our group of the states we majorly draw our patients from. And we basically formed some alliances with some of the local oncologist group, and we gave them access to our information. In terms of with our own people, because, I mean, the transplant group has always been independent of the general oncology group. It comes from the history that the general oncologists were at the U, and the transplanters originally were from Fred Hutchinson, which was independent of the U. And the Seattle Cancer Care Alliance was a merging of 3 different groups to do oncology care, Seattle Children's and Fred Hutchinson and the University of Washington. That everything within 2 to 3 days when you dictate will at least a draft show, even if it's not signed off on, that anybody can look at that's in the center that has access to looking at the patient's legitimate access to look at the patient's records. So that's kind of how we use our U-Link. I mean, it isn't that we give access to docs that aren't part of the network. Again, that's back still to our communicating with a fax of a printed out letter.
Sure. And I know that even when we were there conducting the workshop, there were several discussion about how your network continues to grow and evolve, and you've got new members joining. And so we even had the opportunity to mention U-Link and educate some of the staff, the office staff, the clinicians about that resource. So it's great to hear, and we certainly look forward to following up and learning more. On this next slide, it just sort of maps out that follow-up process, because we found over and over that patients in some cases were confused about, well, at what point do I follow up with the transplant center versus my regular primary oncologist in my own community? And it was really clear that there was a need for some more structured education, perhaps even a calendar, so that the patients really understood where to go for certain tests to make sure that tests are not getting repeated unnecessarily, but also to ensure that the right information is being transmitted to both the transplant team as well as the primary oncology team. So on this next slide, we know that at Seattle, you all have a structured patient calendar that you send patients with, and we actually took that calendar and shared it with a number of other centers as we traveled and as we talked about this program. And everywhere we went, where we showed them that, yeah, this kind of structured form that the patient has, the primary oncologist has, it really clearly lays out what tests need to be done and if certain things need to be ordered, vaccines, that helps with the care coordination. And everyone agreed. Very few organizations were using such a structured tool. Can you just elaborate a little bit more and just share with us how this has impacted care coordination on the follow-up end?
So what we used to do, since it was very attending specific as how thorough they were with patients, we used to tell the patients this kind of information verbally. And we used to also, depending again how what the attending, how much they wanted to add to their discharge letter. Some attendings were better to put all this information to a referring doc, and others were more skimpy. That we felt that this was a better way to standardize where the information was easily out there for both the patient as well as the doc. So the patients get 2 copies of this, one for them and one to give their doc when they leave. So they hand deliver it to their doc. And I will say, I think this has definitely made it less confusing for docs in the community as well as patients. And it really is giving a better ability for them to interact with each other and make sure they don't miss any of the milestones. Now, I will say we're a little different in terms of our long-term follow-up. Allo transplants, where you get a transplant from somebody else, are markedly different for how we manage them long-term than autologous patients where you get your own cells. Autologous patients really don't usually return to us. Once they're ready to leave us and go back to their doctor in the community, they're not coming back to us for restaging studies, and that it's all done with recommendations to the doc in the community. And then our long-term follow-up office is where we get records from docs. We usually will serially, once a year, send out a questionnaire to the patients as well as to their doctors, and ask them about what's going on, how's the patient doing. The patient questionnaire is very detailed. It has a lot of quality of life issues questions asked too. And we have people who go through this and read. And anything is flagged, they bring it to the attention of the staff of physicians that work with long-term follow-up, and we follow up with calls to the patient, and we follow up with calls to the doc in the community.
Mm-hmm. Okay, great. Well, thank you so much for sharing that. And I think you've got some model examples, and this type of calendar tool and a resource, I think, has really become, in essence, a best practice that we've now been able to share with the broader ACCC membership. On the next slide here, we just highlight some technology tools and resources that we know exist today, but as we mentioned earlier, they're not necessarily overly utilized, or when you're talking about perhaps the multiple myeloma patients and the demographics of these older adults who may not necessarily use mobile devices as actively as, say, younger patients. We understand that the limitations of some of these tools need to be tailored and customized. You have to provide, for instance, your education using a multimodal approach, a multi-channel approach. So you've got paper, you've got electronic, you've got email, you've got mobile, etc. And then on this next slide here, we also, as we mentioned earlier, in terms of the barriers of interoperability, we know that currently the government is really pushing for major changes and improvements in interoperability. And so the Department of Health and Human Services has outlined an entire strategy around health information exchange, HIE, and we know that in different states, as we mentioned earlier, that they're much further ahead than others. I think for those on the webinar, if you're not in touch with your local health IT department, I would encourage you to talk to them and see where are you in this whole roadmap of interoperability, and what's happening with the providers in your community, whether they're hospitals or independent practices that are not necessarily part of your system. Because here on this next slide, you'll see that as the government has sort of outlined their roadmap, they have certain goals, and they want to see you know, that interoperability attained and achieved, you know, by certain years as it's sort of outlined. And of course, every year they kind of revisit this roadmap and they update it. But the links are available there on the slide, and I would encourage you once again to share this information with other clinicians in your team, because whatever can be done to minimize the use of faxing and printing and mailing records, if there are ways to leverage interoperability portals and exchange that information electronically, it certainly improves efficiency, reduces the use of paper, and ultimately can just improve in terms of the overall care coordination. So as we get ready to wrap up, and I just want to remind those on the webinar that if you all have questions, you can ask those questions through the chat box. But on this next slide here, you know, it really became clear, and we've talked about some of these things in terms of that post-transplant management. You know, there are certain lab tests that need to be done. Patients may require maintenance therapy. They may require vaccines and other preventive care services. And just making sure that all of that gets coordinated appropriately, I think, is so critical for the patient. What we found as we talked to different cancer programs and surveyed them, we found that some of this happens by the transplant team, some of this happens by the primary oncologist, and in most cases it's kind of a combination. It's a mix of organizations doing this. So using a structured calendar, making sure that there are clear you know, roles and responsibilities of knowing who's doing what, where is that information getting shared, and ultimately allowing the patient to become more engaged and empowered in his or her own care. The next slide here just talks about the Institute for Healthcare Improvement's model for improvement that they encourage healthcare organizations to use, and they really leverage the Plan, Do, Study, Act, or PDSA cycle. Some people will call this the PDCA cycle. They use check instead of study, but the whole idea is still the same. And so as we concluded the workshops at each of these transplant centers and talked with both the transplant teams, the referring oncologists, the office staff, the nurses, the social workers, and the transplant coordinators, you know, where are there opportunities for improvement? You know, what could we start doing differently? You know, small little nuggets of ideas started to emerge. For some, it was a matter of simply just saying, let's start using a discharge calendar like the one that Seattle Cancer Care uses, and, you know, let's incorporate that into our practice. Some other ideas included leveraging a common communication tool that referring practices can use, like a single-page brochure that, you know, every referring practice, if they're going to refer a myeloma patient for transplant, could just sort of walk through the same steps so that that patient is properly educated and equipped. Other examples included, instead of waiting for that discharge summary, having a shorter one-page synopsis where you just kind of highlight the summary of the discharge, but just essentially it's a summary of the summary, and then you immediately send that off, just like you had mentioned, Dr. Holmberg. So I think a number of these ideas surfaced, and then here on this next slide, you'll see that our sort of instructions for each of the cancer programs was to say, all right, these are great ideas. Now, in order to really operationalize them, to make sure that there's appropriate follow-up and measurement, let's use these Plan, Do, Study, Act worksheets, and let's assign responsibilities, know who's going to be following up, who's going to measure, so that we can really know whether or not the changes that you all made actually had the kind of impact that we anticipated they would, and to make sure that there's accountability and follow-up and engagement, and so that every organization can celebrate those small little wins. I think at Seattle Cancer Care at the time, there was also a lot of discussion around just that whole preparedness and making sure that when patients are being referred for transplant, are they prepared? Are they adequately ready? You know, have they identified a caregiver? Have they mapped out the resources that they need so that they can say yes when they're presented with the option for transplant, as opposed to saying, you know what, I think this is going to be too difficult or it's going to be too much of a burden. So there were a number of these kinds of ideas, and so all of these discussions and ideas led to PDSA worksheets that ultimately every group prioritized and then had to decide from there where they were going to focus. So as we wrap up on this last slide, I think the takeaways and the summary is that, you know, there are clearly still opportunities for improvement, and, you know, as we focus on this whole issue of coordination of care and medical co-management, there are so many areas even within those broad topics where we're talking about patient records and just even basic communication from provider to provider. You know, how can we improve that? What can happen at an organizational level? And so those are some things that we know that we need to continue to work on, and it's going to be an evolving process. And just like the Plan, Do, Study Act is a cycle, we have to continually reassess and re-examine. We've gotten a few questions from the audience, so at this point I'm going to ask some of these questions to Dr. Holmberg. The first question is, do referring physicians have direct access to know who the transplant physicians are? Because you had mentioned a rotating schedule. If they wanted to directly contact the transplant physicians, do they have a different way of reaching you, or do they still call the same number and then allow the operator to sort of connect them? How does that process work?
So the intake office has a set telephone number. It also has, we have an email account that they can email directly if they don't want to call. And it goes to the transplant physician who's the attending, who's assigned to the intake office for the month. And so if they want to talk to somebody directly, they say they want to talk to Joe Smith, for example, we have all our phone numbers of all our faculty on the web page that they can get the office number to call them directly. They also, if they're local, they know that there's a toll-free number they can call through the UW to and MedCon.
Okay, okay. Thank you. Another question that came in. Yes, go ahead.
Could I bring up one thing? I think one thing that I saw, and to point out, is just the education of the patient and practical things about how to manage when they get home. For example, when do they stop an immunocompromised diet? When can they go swimming and all? And I think that was one thing I kind of saw missing off of this. And I'll just put a comment about how we handle that, because I think so we have 3 different routes for patients. We have classes where they can go to before they're discharged, that they can go and hear about all the long-term management issues that they're, and how practical speaking, what they can do when they have a Christmas tree and all that. We also have it online, so if they type of person wants to go online to read it. We also give them a manual, a book when they first come to our center. That part of that manual is not only, you know, the common things you want to know about when you're getting a transplant, but also when you get home, these are the things that you need to deal with. And then we have the long-term follow-up, which is manned, as I said, Monday through Fridays, and they're given the phone number on departure, and they can call in for any question anytime. Because I think that's an important point of all of this, is just empowering the patient to know exactly, also just the general nuts and bolts about what type of things they want to do post or transplant.
Sure, absolutely, and thank you for those comments. Just as a reminder for those on the webinar, today's webinar is actually webinar number 3 of 3. Webinar number 1 actually focused around a lot of the patient education components that we learned from this project. The second webinar focused around psychosocial support and sort of that whole process for patients, knowing that remains a significant barrier. And then, of course, today's talking about coordination of care and that whole co-management piece. Another question that came in from the audience was, you mentioned once again that you've got this rotating schedule. So if a patient is discharged, and then if a question comes up about that patient's care, does the question go to the transplant physician who is on service, or does it go to the transplant physician who cared for that patient? So could you answer that question, please?
So that's kind of attending specific. So I'll tell you personally what I do, but that's not what all attendings do. When I send some patient home, I usually will give the patient my card, say if you have questions, here's my phone number. I honestly have an answering machine, pick up the number I give patients, but I also will always give my phone number to the referring oncologist when I send a patient home. That's my preference, but I also do give them our long-term follow-up number, the referring oncologist, and really that's kind of what most people use, is that since we're a rotation system, that we have a long-term follow-up group that is committed to taking and dealing with long-term management issues, both from the referring oncologist standpoint, that are medical issues, as well as the patients. That could just be things, can I have a Christmas tree this year? That's live, and that's what most of the communication through is our long-term follow-up. And as I said, when the question's brought in and it needs a physician's input, then there are different doctors that work full-time there that are assigned to deal with autologous patients versus allogeneic patients.
Understood. Okay, thank you. Looks like we've got time for one more question. So this question that came in from the audience is around maintenance therapy. How are decisions and recommendations regarding maintenance therapy made and communicated between the transplant physician as well as the primary oncologist and community? Can you just tell us a little bit about how that is managed?
So we have clinical trials with maintenance therapies, and so frequently patients are talked to about their interest in returning to participate in a clinical trial. The recommendations that are given to the referring oncologist in myeloma will be, this is our standard restaging is around 80-100 days after an auto transplant. It's not that dramatically different after an allo either for myeloma. And then we'll say, looking at your patient's history, I'm sending you home. My recommendations would be if they are a candidate for maintenance versus another auto transplant, and what would be the criteria to think about another auto transplant, is that these are standard of care maintenance regimens that are out there. And then also to discuss if you think the person will be a good candidate for a clinical trial. These are the trials we have, and just contact us if you're interested in getting your patient back. And usually the contact for getting a patient back onto a trial is the PI on the trial.
Understood.
Principal investigator.
Right. Well, thank you very much. We are now actually out of time, so I want to remind everyone on the webinar that on the ACCC's website under Provider Resources, you'll actually find a transplant treatment path communication guide that's available as a PDF, and it summarizes a lot of these takeaways that we learned from this project. And so thank you for your participation, and thank you to Dr. Holmberg for your comments and for leading us through this webinar. And at this point, I will turn it back to Daryl at ACCC.
Thank you.
Thank you, Dr. Holmberg, and thank you, Dr. Kim. We are pleased that so many of you could join us today. We are going to wrap up this webinar now, but I do want to reiterate that the webinar has been recorded and will be archived on the ACCC website. And if you have any questions, please feel free to reach out to us. And everybody have a wonderful rest of your day. Take care and a happy holidays.
Thank you and happy holidays.